Talk about female reproductive system. Female reproductive system we divided in two portions. One we'll be discussing today and one we'll be discussing the week after, because that part of the we'll be learning with external genitalia. Now in total this is the full female reproductive system. And what are you looking at? The uterus, the ovaries, their tubes, then vagina, their blood supply, and then the organs, the structures which are located within the perineum. Right? This is the complete system. And when you look at the uterus, it has different parts. And these parts are explained by this color coding. Can you see this color coding? This part is called fundus. There is body, and then coming down we have different zones, and this lowermost part is the cervix, and cervix is looking into the lumen of vagina. When cervix is looking in, so you can see that between the vagina and the cervix, can you see this gap here? Can you see this gap here? These are the side gaps. There is a front gap, there is a gap on the back. These are called fornices: anterior fornix, posterior fornix, and lateral fornix. Fornices. Together fornices, alone fornix. And these are useful areas. And these are the measurements and all that. This is just theoretical stuff. Are you clear with this? Now, what are you looking at? You are looking at a uterus in reality. No fabrication. This image, this is the real image, 12 times magnified, and you're looking through a lens, through laparoscope. You insert it in someone's abdomen, in a female abdomen, and you're looking, this is a natural color in your body. Right? A normal looking uterus. And you're looking at the fundus and the tubes. Right? And then you're looking at this yellow area, we call it pouch of Douglas, rectum is somewhere here. This is a side view.
The previous picture, it's which view? Yeah. Is it from below or is it from top?
You're looking from top, fundus.
Oh.
Now you're looking at the tube. Can you see you're looking at the ovary?
Yes.
Are we good?
This is the
So these are the real pictures from real patients. Real humans who are living and breathing. Only they are under anesthesia. Now let's come to the sketches. Same thing, let's label it fast. Anteriorly we have symphysis pubis, sacrum promontory, you remember we learned in the labs. My external iliac vessels, urinary bladder, fundus of the uterus, ovaries, rectum, everything is covered. How we are looking at it? We are looking from, if I'm sitting in the abdomen and I'm looking down in the pelvis, this is my view. I'm looking superiorly. And what is this green thing? Parietal layer of peritoneum. And what is this gap? Pouch of Douglas, rectouterine pouch, so many names. A very specific area in female genitourinary tract. A lot of things are happening in this space. And this is the space between the bladder and the uterus. Literally, uterus is the one in the normal condition is sleeping over the bladder. Once a female gets pregnant, she have a lot of time urinary tract infection. Why this is happening? Because uterus is sitting on top of it. Now there is someone who start living in this uterus, and because of this weight and these changes, the person who is having, this is her uterus, she start experiencing some kind of newer things. So bladder get irritated and person will start showing you some signs of urinary tract infection. In the males, they only have vesicouterine pouch. Female have both options. Now this is broad ligament. Guys, I need one volunteer. No, you are wearing a I need someone without a headscarf. Come. And request someone who's not using her tarha. Yeah, yeah, I want a tarha. Guys, this is something which I learned and which I never forgot. I'm just covering you, okay? Don't mind. And you have to put your hands like this. She starts flying. Cover yourself. Guys, this is classically how a uterus is. Fundus, tubes, ovaries are here, and this is the whole body and everything. Thank you very much. I really appreciate it. Are we clear?
Yes.
So this is how uterus is. So these are the supports for uterus, round ligament of uterus. This is the guy who was coming with uterus, with ovary when he was traveling from something similar to gubernaculum. And this is the ovarian ligament. And who's this? A tube, fallopian tube, uterine tube. And this is the fimbria, finger-like processes. We'll be talking about it. Who's this guy? The enemy of gynecologist. Ureter. And this is the ureter guy. Are you fine?
Yes.
Doctor, where's the ligament of the uterus? Like, where is it?
Which one?
The ligament.
The broad ligament.
The round ligament?
Broad.
Broad, I have a lot of images, don't worry. We're spending time with that. Don't worry. So guys, this is the similar thing which we saw with a laparoscopic view, but in reality this much things were there. Now you're looking at a sagittal view of a female pelvis, and what I'm trying to show you here, how the peritoneum is connected to different parts. When the peritoneum dips down into the pelvis, for the rectum, we divide rectum into three parts: upper, middle, lower. Upper part is covered from three sides. Middle part is covered only from one side. Lower part of the rectum is not covered by peritoneum at all. And then this is reflecting, covering all the way, whole uterus, dipping down over the bladder and just blending with the anterior abdominal wall. Are we clear? So journey from 1 to 7. So this is symphysis pubis, sacrum, sacral canal, urinary bladder. What is this? Urachus. Paul always bring question from urachus. This is uterus and vagina. Now can you see this? These gaps I mentioned, fornix. If you know, maybe 15 years back, some crazy people decided, why we cut someone's abdomen to do a surgery? Why can't we use some natural orifices? And for females, it becomes so easy. What they were doing, and it was happening, they were inserting their instrument through the vagina, through this fornix. You puncture it a little bit. You are in the abdomen. You can remove a gallbladder. You can remove anything from someone's body, and patient have no scar, no line, no dot. And if someone says, I have a surgery, where is the mark? There is no mark. But then this idea was dropped because there were some complications associated with that, some contamination and all that. So this is no more in practice. But this was in peak for good 10 to 12 years. Anyways, so this is posterior fornix, and it is pretty useful. A woman who present with recurrent UTIs, a lot of problem, what we do? We do an ultrasound of their pelvis, and if we see some fluid is accumulated in pouch of Douglas, how I can approach to pouch of Douglas? Number one option, I can cut open someone. No, go through vagina, put your syringe from here. Now you are in between, rectum is here, you are in between rectum and uterus, the pouch of Douglas, you are in, insert your needle, suck the fluid out, and you are just inserting a tiny needle, and then send this fluid for all chemistry and everything, and you get every result, and you can start your antibiotics and everything whatsoever is needed. Some women, they harbor their pregnancy in this pouch of Douglas. So there's a lot of things are connected to this pouch of Douglas. Anyways, this is vagina. These are the labias, and this is perineal body, very important. We'll be focused more in our next lecture about this green guy. This is rectum. Are we good? Who is this guy? The one who's behind the rectum. This is the one which you are learning this week in the lab, levator ani. Is a support which makes the pelvic diaphragm. Levator ani muscle, and it goes all the way. And then rectum has the strongest sphincter in our body are around the anus. And if someone loses control on feces, means spinal cord has disastrous injury, or there is something severe happened with the control system of the body. So these are external anal sphincters. Now this is what? Endopelvic fascia. This is not peritoneum.
Transversal.
This green guy is endopelvic fascia, very important. And then we have peritoneum. There you go. Are we good? This is my pouch of Douglas. So can I not put a needle from here into this gap, suck out the fluid, patient will not have any pain or any problem, send it to the lab, you reach to the conclusion. This is the vesical pouch, this is clitoris, and everything is in a packing. Call it Camper's fascia, and there is a Scarpa's fascia. Just ignore today, it will be useful in our next lecture. The venous plexus. Now, we are looking at a uterus from the front with the tube. Now think of her when she was wearing that tarka. Right? This is her arm, and this is where we have tubes. Ovary lives somewhere here. So let's start labeling. This is the cavity. Fundus, number 1. Can you see, guys? Number 1.
Yes.
Fundus, body, isthmus. What is number 4?
Cervix.
Cervix, excellent. Number 5?
Vagina.
No.
No.
Vagina is this. Vagina is this. Cervical canal. And then this guy is external os, this is internal os. Internal os, external os. Are we good?
Doctor, what is the full form of us?
It's a name.
Opening or what?
Yeah, it's called external opening. Let's make it easy for you. External opening, internal opening in the cervical canal. Now this is what? Lining. No epithelium. Endometrium. Epithelium is epi. Epi means up. Endo means in. Deep. Are we good? Myometrium. Endometrium, myometrium. Ask me what you are struggling.
I got it.
This is vagina. Fornices of vagina. Can you see number 10?
Yes. Vagina.
And what is this tube?
Fallopian tube.
Uterine tube or fallopian tube. Now let's take its parts. Isthmus, ampulla, infundibulum, fimbria. This whole thing is together called fallopian tube or uterine tube. Are we good so far?
Yes.
Everyone?
Yep.
Are you with us? I think you are doing some news readings or something. What is it? I'm talking to you, don't look behind. If it's that boring, you can walk outside, have little fun. Because when you have unnecessary movements, I thought you are struggling with something, so I'm just focused more on you. Don't think I'm ignoring you. This is ovary, and these are what? Inside the ovary. Yeah, perfect. So they are maturing and everything is happening. Got it?
Yes.
This is the journey of an ova. If you found something, if ovary is not here, then coming from posterior abdominal wall, this guy might be lost. And a lot of pregnancies are happening in the loops of intestine. Ectopic. But it's not happening because it's calm. Are we good so far? Corpus luteum. These are the different phases. I think Jabbar must have talked about these things. Corpus albicans, when it goes wide after releasing ova, these are the changes which occurs with the follicle. Are we fine?
Yes.
Ligament of ovary, you are asking about it. It's there for you. Now I'm just mimicking you. You remember I asked you to wear a tarha and it was covering your arm. You have one fold of tarha in front, one fold of tarha behind, and this loop, this fold, we call it broad ligament of uterus. Broad ligament of uterus. And this guy, we call it round ligament of ovary or ligamentum of ovary. And there we also have round ligament of uterus. Are we good?
Yes.
So this is peritoneum, two folds, together they are called mesosalpinx. The word salpinx is for tube. Mesentery.
Yeah.
Mesentery of what? A tube. Salpinx. Make sense?
Doctor, so this is one from the
Yeah, one part of tarha which was standing here.
broad ligament.
Yeah, broad ligament. So broad ligament. So why I call it mesosalpinx? Because it's going to my tube. Which tube is this? Fallopian tube.
Round.
And here it's again. Now we have a different name for this. It is going to this guy.
The round ligament?
No.
No.
This is mesometrium. And together, broad ligament.
So the broad ligament and the peritoneum are continuous with each other.
Say it again.
The broad ligament and the peritoneum are continuous with each other because it.
I need your tarha again. She don't understand. No, I'll not ask. See, this was peritoneum, and it will definitely go up to go to the liver all the way. This will also go to the liver all the way. It is in the pelvis. So, same parietal peritoneum, anterior layer, posterior layer. This is the tube. So I'm just pinching here. I'm calling this is my mesosalpinx. Then I'm pinching it here between another tube, mesometrium. Make sense?
And this whole thing is called
The whole thing is
broad
peritoneum, and these two folds at this location, these folds of peritoneum, we call it broad ligament.
Okay.
Make sense?
And the round ligament.
Yeah.
Oh.
It's coming up. Thank you very much. If your Torah was not there, my life could have been in a big.
How do you explain to the right section?
Wallahi, that's the biggest thing. And sometimes when I'm explaining in male class, there are few content which I cannot speak very, freely with the girls. Then it's another problem. So it's always something. Are we clear?
Yes.
Now everything is in a cover. Guys, are you with me? Now what I did, can you pay attention? At this gap, the mesentery here, it's been colored. Why it's colored?
Continuous of the.
So now we want to name it. That's why it's been colored. Meso. Read it. Mesosalpinx. Mesocephalic. Same thing. The same guy. Same fold. Are we clear?
Yes.
Here they are cut so that you cannot see that. If I bring it here, you cannot see this cut end. Here it's complete. So it's just falling down. Are we clear? And this is the uterine artery. Uterine artery, why it is not straight? Why it is tortuous?
Go inside the bit.
Why it is tortuous? When this uterus will grow big, when it will become gravid, do you think you need another artery, another extension? So this artery is tortuous, so enlarging uterus will have a lot of artery left with it, so it can reach, because the uterus almost go up, hit your diaphragm somewhere. Are we clear? So this is uterine artery, and this is ureter. Someone must have mentioned to you water under the bridge. You remember this word?
Yeah.
So the ureter is under the uterine artery, not above the uterine artery. Ureter contains urine. Got it?
Yeah.
So it's supplying widely. So this uterine artery, when it goes to vagina, we call it vaginal artery. And what is this grayish area? Think. This is you remember I talked about endopelvic fascia?
Yeah.
This endopelvic fascia becomes thick here around the cervix, and it is making one of the strongest support for this uterus not to fall down, not to get prolapse. Prolapse?
Yeah.
When a woman is multipara or there is some instrumentation, she might complain, I can see something weird getting out of my vagina, and that is uterus. Something coming out of my anus, that is rectum. So if this dark colored thickening of this membrane become loose, become damaged, so this uterus will prolapse. Are we clear? And there is only one way, push it back, sew it. Now look at this uterine artery. When it reaches the gap between the ligament of the ovary and this fallopian tube, this artery now is branching and is supplying to my tube and the ovary. And there is someone who's approaching from sideways. Who is this? Ovarian artery. And they are just anastomosing with each other. Then ovarian vein is leaving. So there is a rich blood supply through uterine and ovarian vessels. Are we good? All these are branches from internal iliac artery, which is a branch of common iliac artery, which is a outcome of aorta. Are we good so far? Now, you're looking at side view. We talked about this before. Position of the uterus. I told you, uterus sleeps on upper surface of the bladder. Someone visit you, we are practicing IVF, Tifl and Habib. Someone come to you and she says, I'm married for last 1 year plus, still everything is normal, I get my hormonal assessment done, everything is perfect, why I'm not getting pregnant? So when you're looking for different reason, you should always look for the position of the uterus. Is it living normally or does it have some weird behavior? So this is a normal position of a uterus. This green guy is the vagina. Now can you see this point A? There is a flexion occurring at this place. So this is a specific angle. If a woman does not maintain this angle, this is called angle of antiversion. Angle of antiversion. And then angle of anti-flexion. If these two angles, uterus does not follow these angles and it is living differently, then for this female, getting pregnant may be little bit problematic. You don't need a surgery, put your digits, maneuver it, and there is a cushioning available, fix it, and then she can go pregnant, there's not a problem. But what is the reverse of it? Why someone who's not getting pregnant? Look at it. What happened to the uterus? It's not following antiversion and anti-flexion. It is retro. Point C is my retroversion and retroflexion. So this uterus needs to be fixed, should be brought forward. Are we clear?
You can press on the rectum, right?
Huh?
The third position and press on the rectum.
Yeah, obviously. Everything is opposite, upside down. I can see a very nice MCQ here. Put these 4 images. Which one of them is normal? Now, what are we looking at? Cervix. This is external os. This is fornix. How you can see this much? There is a specific instrument. We call it stethoscope for gynecologist or obstetrician. When any female come to them, they do vaginal examination, and if they want more details, they put this scapulum inside. These are 2 steel or plastic shelves. You just open it and you have direct vision of the cervix. And you know, pap smear is one of the investigation for cancer of the cervix, very common among female. You open it up and you take the scraping, send it to the lab. So you are looking at a cervix. I can see, when I look at this cervix, I can see she's a nulliparous. I will tell you. Nulliparous means maybe 1 child or maybe no babies yet. So this is that instrument, colposcope. Can you see that? Multipara, priming, and this is before. Got it? After giving birth, after giving vaginal birth, there is an appearance change occurred in this external os. Before, after. Are we clear? This is primary or multi, this is nulli.
This is after giving birth?
Yeah, this is no birth. Got it? Now, this is the uterus, we talk about him. This is, you are looking at the broad ligament. This is the peritoneum, which covers everything. Clear? This is, you are looking at the vagina. So now these are the details. If you have to sterile a woman, she don't want, like she has medical reasons, and she don't want to get pregnant. You have 2 options. Either sterile the male or sterile the female. In our system, mostly female have to be sacrificed. Why not male? So if you have to sacrifice a female, like she don't want to give birth any further, what you can do? Just clip these tubes. You put a laparoscope and you clip it here. This is called tubal ligation. In male, we learn vasectomy. This is counterpart of vasectomy in female. You ligate the tubes, no ova will reach to the uterus. No ova and no ova will reach to the tube, and no ova will get pregnant. So you stop the process, but you have to ligate both sides. Are we clear?
Yes.
Is it reversible? Yes. Because what are you doing? You are putting a clip. But it's not easy. You need someone trained. And if it doesn't work, it's okay. Do IVF, Tifl Nabi. Get her, hyperstimulate her, collect eggs from her. When we do hyperstimulation to a female, especially when anyone comes for IVF treatment, we don't rely on one ova. We give her certain medication which hyperstimulate her, and she make many ovas. So and we follow her up with ultrasound. When her ovary is showing a lot of ova getting matured, we go through this vagina and we target the ovary and we suck out by a needle all these ovas which are getting mature in the ovary, and then we bring this ova out and we just clean, wash them, and on the other end we get sperms from the partner, and then we just catch sperms and inject in these ovas, and then we follow it up next day what is happening, and then within 24 hours who's the best, that we push in the cavity of the uterus, and the other one we can freeze it for unlimited number of years, maybe million years. You can save as many, and then once pregnancy is complete, you can insert the next one, so she can have babies and babies and babies without going through the whole process. So this is how we do IVF. Tifl and Abib. Are we clear? Coming back, we were here with the tube and we talk about it. It has different part: isthmus, ampulla, fimbria, infundibulum. You can see the ovary. Are we clear, guys?
Yes.
Everyone is tired. Yes.
I have a question.
Huh.
During an IVF can to fertilize that?
We always do. That's why you have noticed IVF patient, they have twins. But we save, if the family allows, we save other mature, they are ready. But you can cryopreserve them for I don't know how many years. Are we clear, guys? Which is riskier in what comparison? I will not use the word riskier, I will use the word which is more easy to do. Easy to do is vasectomy. Very easy. Grab a scrotum, locate this vas, chop him away. End of the story. Here you have to give this woman little anesthesia, and then she's sleeping. You put a laparoscope in, identify the tube, clip it, come out. Even it's a short procedure. Both of them are easy peasy thing. But if we compare, the most easy and less compliance is with vasectomy. Now, if you look at the ovarian tube or fallopian tube, it's around 10 inches long and it has different parts. Intramural part, when we use the word intramural, means inside the uterus. Intramural part, isthmus, it's around 3 centimeter, ampulla 5 centimeter, infundibulum 1 centimeter, fimbria, and this is the arterial supply. You saw that the tubes were supplied both by ovarian and uterine arteries. Guys, don't make any mistake. Blood supply of tube, both artery. Now you are asking about this ligament. I will not take long time. I will stop because I can see you are all exhausted.
Yeah.
Should I take 2 more minutes or should I finish?
Finish.
Finish? Okay. I have no problem. I have time.
Yes, finish.
What I'm doing, I'm just cutting here. I'm just cutting here to show you something. Hello. Stop, okay, I'll stop.
No.
See, guys, when I teach you, I don't see. You know what I see? I see your eyes. When I see your eyes are going like this, why should I throw my effort?
Yeah.
I love to teach.
55 babies, anyone? And you want us?
You know, the remaining part was very easy. I can show you.
No.
Where were we? We were.
Doctor, wallahi.
But we were somewhere here.
Here, after.
After that, things were very easy. They were more clinical things. Anyways.